welcome to another round of virtual morning report. Some not so great news. Unfortunately, Rez is not here today, and that's the only bad part of it. Everything else is an upside. The upside is that he's actually finishing his last day as a visiting professor in Geneva, Switzerland, and they rescheduled his. They basically had an event that they had planned out for right now, so unfortunately he won't be joining us, and instead he'll be celebrating a whole month of teaching in Switzerland. And I've missed him a lot because of the time difference and whatnot, although he's been so passionate about VMR that he hasn't missed a day, even though he's been super busy. I see a lot of people from all over the world actually here, and I want to let you know that Reza and I are doing more and more of these really fun engagements where we go and teach either virtually or physically at institutions across the world. Where Reza's in Geneva now, we're actually going to do something in Japan soon. So if you're part of an institution that's outside the US and you would be interested in having Reza and I come nerd out with you virtually or physically, email us at theclinicalproblemsolvers@gmail.com, and we'd love to get to know your institution outside this country better and get to learn and grow with you. But I say that today in large part because we don't need the 5 seconds or maybe sometimes 5 minutes pause for a case presenter. In fact, have the one and only Gurleen here to present a case. Gurleen, do you mind reminding the audience of what you're up to, where you're at before you jump into the case?
Yeah, sure. Hi, everyone. I'm Gurleen. I'm currently an internal medicine intern at Brigham and Women's Hospital in Boston, and I'm really excited to be here to present a case. I haven't been able to make many of the VMRs because of the time differences, but I'm excited to be here today.
It's so great to have you, my friend. All right, let's rock and roll. By the way, if you're in the chat, since Rez is not here, I'm going to fill the void with your presence. So if you have comments in the chat, please, 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 if you can, unmute yourself. I'll tell you when to and to share them. All right, Gurleen, take it away.
Yeah, once we have the whiteboard shared, I can start with the first
Look at that subtle hint, subtle like waiting and kindness to our scribe today. By the way, Gurleen, your presentation on Monday was absolutely amazing. And if it was this Monday, right? Yeah. If folks haven't checked it out, you have to listen to that VMR. But now I'm a little scared because if that's the bar, we're gonna struggle today. All right,
okay,
take
so
it away, my friend.
This is a 60-year-old female who presented with a few weeks of numbness in her bilateral upper extremities. She says it's kind of in her entire arm, but the left side is worse than the right. She's also been feeling that her whole left side of the body is weaker than her right side for around 1 month. It's unclear if the weakness or the numbness started first. And that's all I'll give for the first aliquot.
Oh, that's very, very intriguing and a very unusual chief concern for many reasons. I think that you're starting in a landscape that appears neurological at first glance, and that's almost certainly true. And the neurological world is immediately followed by an attempt to localize the neurological lesion. And here we're getting a mix of sensory and motor features to help us localize, initially focusing on some sensory stuff, and then followed by motor stuff. The problem is that the sensation of sensory issues and the report of weakness don't perfectly map onto true sensory issues and true weakness. So I'm already saying, Robbie, talking to myself in my head, make sure that you're not misled by an asthenic process masquerading as weakness and a metabolic electric process like hypocalcemia causing a sensation issue. But the truth is that there's an overwhelming chance we're dealing with a true neurological lesion. Now, where would a neurological lesion that has sensory components in the upper extremities localize? We would immediately, thankfully, make a myopathy much less likely because muscle involvement wouldn't result in sensory disease. The neuromuscular junction is also a little bit less likely because myasthenia, the most common neuromuscular junction, does not have any sensory issues associated with it. The peripheral nerves are definitely on the hook for a sensory neuropathy with motor components. And then as you start to enter into the central nervous system, you realize that anything there is fair game. It is interesting to study as neuropathy that would spare the lower extremities. If this is in fact a neuropathy, this is a very unusual neuropathy. And the reason is it's already not the classic length-dependent neuropathy. So where am I at? Quite simply, one big caveat is this non-neurologic. If it is neurologic, the most common cause of if it is neurologic, then it's not in the muscle or the NMJ. So it's either in the nerve or somewhere in the central nervous system, brain or spinal cord. What's more likely between brain and spinal cord? I would say patchy disease in the brain and patchy disease in the cord are totally fair game. What's unusual, if we localize this to outside the central nervous system, what's unusual is the most common cause of a peripheral nerve lesion is not at play. Why? Almost all common causes of peripheral nerve lesions, such as alcoholic, diabetic, toxin-mediated nutritional peripheral neuropathy, has the following features. It's length-dependent, it's symmetric, it's sensory predominant, and slowly progressive. And here, many of those rules are broken. There's a lot of motor component. It's not length dependent because it's affecting the arms more than the legs. And it has a very unusual distribution. It has bilateral upper extremities and left worse than right. So automatically here, either we're dealing with a central nervous system disease process or an atypical neuropathic process. All right, Gurleen, I give the mic back to you.
Sorry. Yeah, so second aliquot, so she notices the numbness and tingling is specifically whenever she's swimming or mowing her lawn. Those are some two activities that she's noticed the symptoms with and has had no lower extremity numbness. She's also had a sore throat for around 1 week and loss of taste. She was concerned she may have COVID, so she got tested a couple of times. It was all negative. She has no fever or chills, no recent travel out of state, no tick bites, no sick contacts, no rashes or joint pain. She's also had intermittent sharp chest pain, which she also experiences after she's done swimming, and it's unclear how long that's been going on for. The chest pain is not associated with dizziness or diaphoresis, and she's had no lower extremity edema, orthopnea, or shortness of breath. In the past, she's had some syncopal episodes. She had undergone a stress test at that time, which did not show any abnormalities, no flow limiting disease, and normal LV systolic function at that time. And the most recent episode of syncope had occurred a few months ago while she was biking. And overall, during this time period, she's felt very fatigued, but denies any weight loss or night sweats. And that's it for this aliquot.
Oh, this is so intriguing. I think there's so many threads that are developing in parallel. There's this neurological syndrome, which we now hear is exacerbated by certain activities such as swimming or mowing our lawn. We learned that there's a pharyngeal component, and we learned that there's a thoracic component and a background of just not feeling well. And I would probably be analyzing all those things in parallel before we try to merge them together. And because we started off with the neuropathic component, let's flesh that out. What do we make of the fact that this phenomenon of worsening when swimming and mowing our lawn? And I think it's a great reminder that our instinct, whenever something happens with activity, is to map it onto some sort of vascular pathology. So the classic story is chest pain that worsens with exertion is somehow reflective of coronary ischemia, or that leg pain that worsens with exertion is reflective of peripheral arterial disease. And here you might say, well, what kind of neurologic process may be affected by vascular disease? And that's where it's a reminder that although most vascular disease results in central neurologic dysfunction, i.e. strokes, there are peripheral neurological diseases that can result from vascular insufficiency. And those would essentially be the symptoms of subclavian steel here. And I say that because it's easy to imagine how a lot of arm motion is involved in swimming and mowing her lawn. But it also may be that it's independent of vasculature and it's arm motion causing compressive issues. So compression in the brachial plexus potentially, or compression in the cervical cord. So what does those two activities say? They say, hey, make sure there's no vascular process here or a dynamic compressive process. such as that in the brachial plexus or in the cervical cord. But a compressive hypothesis feels less aligned with the rest of the data. And the rest of the data is hints at a subtle inflammatory disease process. You know, the report of pharyngitis in the background of fatigue are really, really intriguing. We talked about pharyngitis actually a little, either this past week or the week before. And the first question you want to ask with somebody who's having a sore throat is, do they have any systemic symptoms? Because if they do, if they have pharyngitis with systemic symptoms, the most common causes of pharyngitis are much less likely. Most people with pharyngitis from a virus or a benign virus, or most people with pharyngitis from group A strep have the center of gravity of their syndrome right here. So if we're linking this pharyngitis to the possibility that she has a neurologic disease process, we have to go beyond the common causes and invoke less common infections. So what could be an infection that causes pharyngitis and neurological symptoms? Something like syphilis, which is notorious for its wide range of neurological manifestations and in the involvement of the throat. You might go beyond the infectious causes of pharyngitis and think, could this be a lymphomatous involvement of the tonsils and neurological issues? Could this be an autoimmune disease process that is vasculitic in nature, beginning in the throat like Kawasaki's disease, but the age makes that much less likely? Could this be a thyroid issue masquerading as pharyngitis and weird neurological symptoms? Very, very possible. What to do with the chest pain? It's concerning. You know, she has exertional chest pain, and then there's this background that it might be related to the syncopal episodes that she's had. I'm trying to remind myself what other features that she had. I kind of lost track of the chest pain is also with exertion. So I think the focus should be make sure she doesn't have coronary artery disease. But what are the big themes here? The themes are we're separating all these things. We're separating a neurological disease process from a pharyngeal disease process. And the caveats are, we have to make sure this isn't vascular. And the vascular disease process that would connect the chest symptoms to the neurological symptoms is something in the aorta. So I'm asking myself, like, what's a no-miss diagnosis here? The no-miss diagnosis is the one that marries symptoms here with symptoms here. There are many things, brachial plexus issues, cervical cord issues, but the one thing that goes from here to here is the aorta. And a background of fatigue, a background of unclear chest stuff, syncope stuff, I would say all of this in real life is going to involve in parallel. Figure out the neuro stuff, figure out the pharyngitis, figure out the chest pain with our basic evaluation. But this is a patient who I'd probably be feeling for the radial pulses much closer than I would otherwise. This is a patient who I'd pay attention to their aorta on the chest X-ray much closer than I would otherwise. But I'll pass the mic to Gurleen to give us some more information.
Yeah, that was great. So for past medical history, has a history of exercise-induced asthma, hypothyroidism, depression, GERD, and IBS. This also has a history of abnormal involuntary movements in her left arm and hand since she was a teenager. And her home medications include albuterol, levothyroxine, sertraline, clonazepam, estradiol, fluticasone, and topiramate. Has a family history of lupus and thoracic aortic aneurysm in her father and lung cancer in her mother. For social history, no smoking, alcohol, or drug use. And then I'll also give the vitals in this aliquot and physical exam. So temperature was 36.7, blood pressure 147/72. Heart rate was 72, respiratory rate 18, and setting 100% on room air. General no acute distress, she was oriented ×3, no pallor, scleral icterus. She had some white plaques on her tongue, but no tonsillar or pharyngeal edema or erythema. For cardiovascular exam, regular rate and rhythm, normal S1, S2, no murmurs, rubs, or gallops, and no carotid bruit. For lungs were clear to auscultation bilaterally. Abdomen was soft, non-tender, non-distended. In terms of extremities, brachial pulses were not palpable bilaterally, but they were present and equal on Doppler. And she had 1+ radial pulses and 2+ lower extremity pulses. For musculoskeletal, no joint tenderness or deformity. And neuro exam was largely normal. So cranial nerves 2 to 12 were intact, normal sensation bilaterally, and 5 out of 5 strength to upper and lower extremities bilaterally as well, and no skin rashes or changes in the skin.
Arlene, can I ask you a question?
Yeah.
Did you see this? Did you see the patient at this point? Or
No, I didn't. So this was a patient on my team, but I never actually saw her physically. Not
well,
on my
one,
side of the list.
thank you so much for presenting her because this is absolutely unreal. I, I work in the ER and we have to move quickly all the time. And there's no way if I didn't have the time to sit and think with you all and go through this process, would I have thought to check the pulses closely. So whoever did this,
I think it
massive
was a
shout.
med student.
Really? Do you
Yeah.
remember their name? You should totally shout them out if you do. But if not, let me know afterwards. I would love to let them
Yeah,
know
the
how.
the med student on our team, Suraj Shah from Tufts, was the one who took care of this patient.
Oh my God. I mean, that is absolutely huge. Like, think about it. I'm sitting here having yogurt, like in my chair, like, something in the chest and the extremities aorta. But like to do that in real life, we all know it. If you've been in real life medicine, there's no way I would have thought to do that. And so massive kudos to them. I don't want to put too much emphasis on that, to be honest, because detecting the pulses in real life and having a confidence 1+2+ is actually hard. And we all kind of like just guess. But in this syndrome, I think it's hard not to worry about the thing that connects the arms and the chest and worry about the aorta, especially now with the fact that there is a difference between the pulses in the upper extremities and lower extremities. And so specifically what we'd be worried about is the thoracic aorta. The other dimension of this case is the white plaques on the tongue. And, I think that most commonly that evokes the possibility of mucocutaneous candidiasis, which makes us reflexively think about the possibility of HIV. And that arc is very important to use in everybody. But if you marry that with the base rate of disease, a lot of people just have a dry mouth and have white plaques on them. And then also local immunodeficiency can result in mucocutaneous candidiasis, be it from her exercise-induced asthma and the inhalers that she might use for that, like steroids, or that she might have Sjogren's syndrome, for example, causing dry mouth immunodeficiency. And then Sjogren's is associated with a wide range of vascular phenotypes, including possibly those affecting the aorta. But this exam helps you make tremendous progress. You now know that there is less blood flow to the arms than there is in the legs, which localizes the lesion, if there is one, to somewhere between the descending aorta and then the subclavians on both sides. And that has to be your focus until proven otherwise. You can focus on that a little bit because the most morbid neurological diagnosis, Guillain-Barré, is not at play, and other morbid neurological diseases like transverse myelitis or other core pathology are much less likely. So now what would I do next? I think if I had detected the pulses in real life, I probably would move to a CT chest with contrast very quickly. But if I'm being authentic, I probably wouldn't have. And so I would rely on the labs and the x-ray to detect if there is inflammation or not. I'll make one final comment. The family history of a thoracic aortic aneurysm here may or may not be relevant. It's certainly enticing to make it relevant because of the hypothesis that some sort of vascular phenomenon in this person's chest is happening. But age-related thoracic aortic aneurysms are very common and unrelated to family history. So it really matters at what age her father had this syndrome. And if he is older than 60, then it's probably idiopathic atherosclerotic hypertensive related disease. But if he's any younger than that, you might have to wonder, wait, does he have a bicuspid valve that's genetically transmitted? Is there Ehlers-Danlos or Marfan's? Or the rarest of all, something called Loeys-Dietz, which has characteristic facial features and an aortopathy. But I don't think we're dealing with just aortopathy, which refers to a non-inflammatory dysfunction, usually dilation of the aorta. You have to worry about aortitis here, or some sort of vasculitis of the subclavians and the aorta. Why? The subacute fatigue. The subacute kind of not feeling well makes me worry that when we see the CBC, we're going to see signs of inflammation. I'd hope to be wrong, but I'm worried about that for sure. All right, Gurleen, back to you.
Yeah, so her father had the thoracic aortic aneurysm like when he was in his 70s. So for initial labs, white blood cell count was 8.9, hemoglobin 14.3, hematocrit 44.5, platelets 330, sodium 137, chloride 101, potassium 4.7, bicarb 25, BUN 17, creatinine 0.93, calcium was 9.8, albumin 4.2, alk phos, AST, ALT, T-Billy were all normal. Magnesium and phos were also normal. Troponin was less than 6. NT-proBNP was 28. ESR was 60, and CRP was 7.9. And then a UA showed some trace leukocyte esterase, no nitrites, 0 to 9 white blood cells. Specific gravity was 1.031 and otherwise normal. COVID swab was negative. And then the EKG showed sinus rhythm rate of 66, T-wave inversions in lead 3, and some non-specific ST segment changes in AVF, T-wave flattening in V2 and V3, but no ST segment elevation.
Oh, Gerlin, you have me on the edge of my seat. I'm surprised by this. I'm surprised by how minimally inflammatory she is. But you know, folks, anyone who's on this call, I'm going to ask you just to be put yourself in the shoes of the person who's first taking care of this patient. There's almost nothing that would compel you to be aggressive about this case, I would say. You have a patient who's having subacute odd symptoms with a normal neurological exam, a normal EKG, mostly normal EKG, and a negative troponin. And I could easily see how you'd be inclined to potentially discharge this patient and have them have close follow-up. And it goes to show you how hard it is to diagnose things in the thoracic plumbing outside the coronaries. We're very good at picking up coronary artery disease, though we're not perfect because of this amazing tool that was invented over 100 years ago, which is the EKG. But plumbing issues affecting the pulmonary artery or the aorta are so hard to detect because their consequences are not so extreme initially. If you think about it, if there's a small clot in the pulmonary artery, blood bypasses it and the body works just fine until that clot gets bigger and bigger or you have an infarction. Same is true of the aorta. If you have inflammatory disease or occlusion of the aorta, it's such a big vessel that things can continue to work until there's devastation. So the reserve, really, here's the root of it. The reserve in the pulmonary artery and the reserve in the aorta, and the fact that they're so deep and hard to find within the body, make it very hard to detect diseases, especially subacute diseases in them. So pulmonary hypertension takes forever to diagnose. Aortopathy takes forever to diagnose unless you get lucky. You get lucky by seeing signs on a simple test that you do like an X-ray. So here, I think there is enough EKG changes and there's enough symptom complex to have a hunch that there's something bad going on. And the next step, anyone has a thoracic syndrome that's not clarified with your initial workup of EKG and chest X-ray, as we'll hear, you have to get a CT. That's basically it. So I think in real life, the decision is, do I go deeper in this patient with a CT with contrast or do I not? I'm biased here. I know Gerline has a fascinating case for us, which makes it harder to be honest. So I will say in real life, it's totally possible that you miss whatever Gerline's about to tell us. But I think if you are worried enough about a thoracic syndrome in somebody, recognize that the pulmonary artery and the aorta have a tremendous amount of reserve and therefore hard to detect acute pathology in. But here, I think you get an X-ray, you might get lucky. You might see a wide mediastinum. You might see notching of the aorta. You might see evidence of pulmonary hypertension. But if you don't, I still think you probably need a CT chest. All right, Gerline, back to you, my friend.
Yeah, so going back to some more history, because the history is always the most important part. So about 3 weeks ago, she had noticed that her vision was blurry from time to time. And about 1 week ago, she had developed some like a worsened bilateral temporal headache as well. That's kind of been ongoing with her blurry vision, but she's never had temporary loss of vision. She had an eye appointment a few months ago, and at that time, there was no abnormality. She had no glaucoma, no other vision issues. And then I have one more aliquot after this.
changes everything, y'all. We were focused on the aorta for good reason. And now we have an aorta plus a head syndrome. So whenever you're in this, whenever you have vision changes in an older adult, you have to worry about giant cell arteritis. And I say that, I don't say temporal arteritis, I say giant cell. Why? Temporal arteritis implies that the disease is located in the temporal artery, and that's not true for about 40% of patients. In fact, 40% of patients have no temporal artery involvement of their giant cell arteritis, and in fact, their syndrome is focused on the aorta. So I would love for you to reframe our understanding of giant cell arteritis to say it is a large vessel vasculitis with a predilection for the temporal artery, but if the temporal artery is not involved, it often involves the aorta. So here, I think this piece of history is a game changer, and it makes us worry that this patient has a vasculitis involving the aorta and the temporal arteries, specifically temporal arteritis. What progress can you make to understand, to augment the pretest probability of it? It is really to look in the back of the eye and to see if there's vasculitic changes involving the retinal vessels, specifically the central retinal artery and the ciliary arteries. And a certain pattern of disease in those arteries is evocative of a vasculitic arteritis. But I also think you need a CT chest to look for aortitis. A couple of humbling things about giant cell arteritis. It's crazy. 20% of patients with giant cell arteritis have a low ESR. 20%. We just had a patient here in the emergency room who had an ESR of 5, who had biopsy-proven temporal arteritis. So be careful. You can have a low ESR and have temporal arteritis. Here, the ESR is high, but it's actually not that high for the patient's age. The ESR here is minimally elevated. It goes to show you how humbling it is. But anytime you're entertaining the possibility of vasculitis, you have to entertain the possibility of vasculitis mimics, of which there's a long list, but for the sake of time, I'll tell you that endocarditis is the most important one. So you should consider getting blood cultures on this patient. The fatigue may have been vasculitis all along, but this is a good time to go back to the patient and ask for more symptoms that might be further support your diagnosis of giant cell arteritis. And those are symptoms of polymyalgia rheumatica, PMR. Only 20% of patients with PMR go on to develop giant cell arteritis, but in patients who have giant cell arteritis, 60% of them either have, are having, or will have a PMR. So that's another good way to augment your chances of diagnosing giant cell arteritis, is to ask about shoulder stiffness and about shoulder, neck, and hip stiffness. So this train is moving very fast towards the possibility of giant cell arteritis. And if this is happening to you in real life, slow down. You want, in diagnosis, when you're nearing the finish line, you want to be as light as a feather and not as immovable as an elephant. You are at risk now of becoming the immovable elephant that stands on the path to GCA and nothing can move you. You should move very fast towards GCA, but you should stay as light as a feather, because if something else comes your way that surprises you, you should be able to blow in that direction and not stay anchored to the world of GCA. But it's definitely the train that I'm on for now, but I'm ready to be taken any other way that Gurleen is going to take us.
Great. So she got a CT head and neck, which showed no acute intracranial abnormality, no large vessel occlusion, and there was some apparent mild wall thickening along the bilateral subclavian and axillary arteries, which the read from radiology said maybe artifactual or perhaps secondary to non-calcified atheroma. There's also some other findings of soft tissue prominence in the lingual tonsil, secondary to lymphoid hypertrophy, no tonsillitis epiglottitis, and a 4 millimeter density along the posterior wall of the midtrachea. Unclear etiology, could be secretions based on the radiology assessment. She also got an MRI brain and spine, which showed no acute intracranial abnormality, just some degenerative disease. And then some additional labs, B12 was normal at 537, TSH was normal at 2.4, ANA was less than 1 to 40, ANCA was negative, acetylcholinesterase antibodies were negative, C3 was 131, C4 complement score was 33. Also got some infectious studies. So hepatitis panel was negative, Lyme, HIV, Ehrlichia, and Babesia were negative. EBV early antibody was positive, and RPR and treponema antibody were both negative. And this is the last aliquot.
Really, you've done a marvelous workup to look for other causes of vasculitis. Ironically, sometimes looking for infections like Hep C that can cause cryo, looking for infections like syphilis that can cause an aortitis, looking for complements that would be consistent with a small vessel vasculitis. For a fun fact, there is a small vessel vasculitis that can affect the aorta, and that's GPA, granulomatosis with polyangiitis. And the reason that is that the vasculitis of the aorta actually is a small vessel vasculitis of a large vessel. So you can actually get a vasculitis of the vasa vasorum, which are the small vessels in the aorta. So here that ENCA makes that much less likely. I think it's interesting. When we talk about Kushal, by the way, I saw your note. That's also another way I think Kushal would put this. That's the mechanism by which syphilis causes aortitis, is it actually affects the vasa vasorum. This is a really interesting thing. Takayasu's and giant cell arteritis are the two big players in the world of aortitis. And often the distinguishing feature on imaging for those two things is to look at the accompanying vessels that are also inflamed. So if you tell me nothing about the patient, not their age or their demographics or accompanying symptoms, if you just tell me aortitis plus subclavian involvement, I'll tell you it's Takayasu's. If you tell me aortitis plus extracranial involvement, like carotid or vertebral or temporal, I will tell you it's giant cell arteritis. So here, we're moving towards the vasculitis train because of the reasons we've talked about. And the subclavian involvement and the possibility of the subclavian involvement and the possibility of a vasculitis syndrome suggests Takayasu's. But Takayasu's is usually in younger women, heralded by an inflammatory syndrome characterized by erythema nodosum, joint involvement, followed by this. So that's a little bit less likely. So here, I think you have to presume this is giant cell arteritis, empirically treat with steroids, get a biopsy, and if that is not fruitful, we can reanalyze the case. So honestly, I'm not thinking too hard about any of the data because none of them are compelling to move us from the train we were early on. So even if this analysis is wrong, I think it's the right thing to do until you get the biopsy. So in this patient, collect the blood cultures, start the steroids, get the biopsy, and then reassess. What could you possibly have? You probably could have missed a lymphoma hiding in Waldeyer's ring in the back of the throat that's causing these symptoms. You could miss an esoteric infection, which I can't even begin to reflect on now because it would be really surprise me. Or you could miss endocarditis because endocarditis is the most humbling thing of all. All right, Gurleen, mic to you, my friend.
Yeah, I'm learning so much from your discussion. So to follow up on the CTA abnormalities, she got an MRA of the chest, which showed mural thickening and enhancement of the proximal left subclavian artery, similar to the prior CTA findings. Also showed wall thickening of the proximal right subclavian and moderate to severe narrowing of the distal left axillary proximal left brachial artery, as well as moderate narrowing of the right axillary artery. And overall, the findings likely represented vasculitis was the read from radiology. There was no wall thickening or enhancement of the thoracic aorta, no thoracic aortic rupture, aneurysm dissection, or intramural hematoma. Then she also got a temporal artery ultrasound duplex, which showed that, so the ultrasound showed axillosubclavian arteries had wall thickening consistent with arteritis, but the temporal arteries were normal bilaterally. So the final diagnosis that was made in conjunction with rheumatology and with the whole team was of giant cell arteritis. And early on, when this was suspected, she was started on IV methylprednisone earlier on. And she got an MRI angio of the abdomen later on as well, which showed neural thickening enhancement of the lower thoracic and abdominal aorta, more prominent in the infrarenal aorta, likely representing large vessel vasculitis. And from the rheumatology, no, I did say that her initial presentation, as Robbie mentioned, is her age and demographics go with giant cell arteritis, but her distribution of vessel involvement is more consistent with Takayasu's. So the teaching points that kind of I thought about and kind of refined my illness script for giant cell arteritis included that, so giant cell arteritis, as we know, is one of the most common systemic vasculitis, and the greatest risk factor is age, and the classic age of presentation is greater than 50 years of age. And as Robbie mentioned, around 20 to 40, there's varying amount percentages reported, but sometimes 40 to 60% of patients with GCA have polymyalgia rheumatica, which is characterized by aching and stiffness in the shoulder or the hip girdle. And commonly, GCA presents with systemic symptoms like fever, fatigue, weight loss, but headache can be a very common presentation, as well as jaw claudication, as well as transient visual loss or amaurosis fugax. And usually in GCA, it's the large vessel involvement of the aorta and the proximal branches like the external carotid, but as here you can see that some other arteries were also involved. And what I found interesting when I was like kind of reflecting on some of her other symptoms like sore throat and things like that were that GCA can sometimes present with upper respiratory tract symptoms, sometimes even a non-productive cough. And that usually occurs because of vasculitis of the ascending pharyngeal artery, which is a branch of the external carotid. So some other like non-typical symptoms are also important to keep in mind. And then the jaw claudication that's sometimes seen in these patients, which this patient didn't have, but that can also occur because of other external carotid artery branches that supply your muscles of mastication. And physical exam, you want to keep an eye out for abnormal pulses, blood pressure changes between the two extremities, any murmurs that would signify like aortic pathology, as well as bruits. And as Robbie was mentioning, a characteristic lab abnormality is a high ESR, but that's not necessarily always the case.
You're an attending, basically. You might as well just come, when you come to San Francisco to visit in the near future, just stay and work here. That was a masterclass. And you know what's so cool is how effortlessly you're delivering it. You're delivering it, you're not reading it, you know it. And that's just marvelous. When we, I'll pass the mic just to Kriti to teach us, but I wanted to share something with you. For those of you who were at the beginning of this case, rewind the clock back with me. Remember when we first heard the first aliquot? I will tell you, I was convinced this was going to be a neurological disease. Remember that? I'll read Gerline's first aliquot. 6-year-old female presents with numbness in her bilateral upper extremities and her entire arm, left side worse than right. She also feels her whole body weaker on the left and the right. This is why it's so crucial to even when you become an expert in something, say neurology or rheumatology, your core training in general medicine is fundamentally important because medicine diseases can fool you like no other. And so remember that moment when I will presume that most of us thought, oh, what fancy neurological disorder is this? Is this Guillain-Barré or is this transverse myelitis? And you have to remain humble to a systemic disease masquerading as a neurological disorder. And I'll just share my short list so you're armed with that. Whenever you're like, I'm in the world of neurology, but it turns out to be something else, you're either dealing with a vascular issue, a calcium issue, or an endocrine issue, like hyperthyroidism or periodic paralysis. So in my mind, endocrine, vascular, and electrolytes are the ways in which something purely medical can really show up as something purely neurological. But thank you, Gerline, for an absolutely marvelous case. And I would say probably even better teaching afterwards, which is hard to beat a case of GCA presenting kind of like Takayasu's, which was really cool. All right, so Kriti, we missed you on VMR. It's a delight to have you back. Take us home, please.
Thanks, Gurleen. That was such a great case. Every time Gurleen is on VMR, we all know it's going to be a treat. So in terms of thinking of this case, I know that Gurleen and Rabi have given us some amazing teaching points. So I'll just sort of go over the journey that we took. And so we started with this symptom of weakness and numbness. And basically we deconstructed this in 3 parts. The first one was to think, is this, and I know Reza put a really great tweet recently about what makes a good schema. And I think one of the first points was that think about the mimickers. So right off the bat, we were thinking, is this a true neurologic syndrome or is this asthenia? And then we were thinking, if this is a true neurological syndrome, the next thing to do would be to localize where the pathology is occurring. And so the presence of the sensory pathology localized the weakness essentially to the peripheral nerves and the central nervous system. And what was really strange in this case was the distribution of the sensory neuropathy. So we had upper extremities affected more than the lower extremities. And this made us think about a length independent peripheral neuropathy or a central process. And so we went about the case, keeping these things in mind and then collecting clues. So our first one was that the symptoms are worse with activity. And a great way to think about this is that this equals essentially a vascular process. We've heard Rabi talk about it before in terms of chest pain, this being a vascular process, but also in terms of the abdomen. So you know that when there's abdominal pain that's worse with eating, that's essentially like a stress test of the abdomen. And one of our differentials is there a vascular process? And here, well, there could be a dynamic compressive process at play. Just the fact that we were getting signals of inflammation of vascular process was more likely. The next clue that we got was the pharyngitis, the sore throat. And then we had to think beyond the common causes of pharyngitis, like a strep throat, just because of the neurological symptoms that this patient had. So we were thinking pharyngitis plus systemic symptoms. What is this equal to? So you think about infections, atypical organisms, but also thinking about the sequelae of some infections. I know we've had like a lot of cases of Lemire syndrome on VMR. So these are things that you keep in mind. And then the others are like malignancy and autoimmune. This patient's age made something like Kawasaki less likely, but leukemia and lymphoma was definitely on the table. The next clue that we got essentially was this patient's family history of the thoracic aortic aneurysm. And I think this is something that I keep in mind even as a learner, is that when we take family history, when we get positive family history, think about ask for when the patient was diagnosed, especially because this can help you differentiate between something that is benign versus something that is super concerning. So here base rate would favor like an atherosclerotic process. But if this patient was diagnosed at an earlier age, and there was a great NEGM that I was discussing with Kirtan earlier last week, vascular Ehlers-Danlos, and so I'd recommend anybody listening to read it, that this could indicate Ehlers-Danlos or Loeys-Dietz syndrome. And then the last was we stressed upon the importance of the physical exam and the history, and that was actually one of the things that helped us help Gurleen and her team solve the case. So the first one was the white plaques on the tongue. This can again be seemingly benign, could just be due to dry mouth, but it can also indicate a localized or systemic immunodeficiency. And then we talked about the peripheral pulses and the importance of the physical exam, although not extremely sensitive, but it's definitely essential, especially since we discussed about things like an aortic or thoracic syndrome. You probably need to have, and I'm not sure if I interpreted this right, but you probably need to have a lower threshold for diagnosing these cases, just because it's harder to diagnose them, especially if they're subacute. So your physical exam will possibly direct you into whether you need further testing or not. And then in terms of framing this hypothesis, so we were still pretty grounded on whether this is neurological and vascular, or whether this is just vascular and infectious, or vascular and a malignant process. But I think we went back to the history, as Gurleen said, and then this patient also had the EKG changes, the blurring vision, and that sort of honed us on a vascular process. And here, the big one at play was giant cell arteritis. And I know Gurleen talked about the illness script, so I won't go back, but I think a point that Rabi made was that although only 20% of patients with VMR have go on to progress to have GCA, 60% of patients with GCA can have an underlying VMR. So a good thing to ask on history would be, ask for shoulder, arm, hip stiffness. And then Gurleen and her team did a very thorough workup in terms of thinking about other things that can cause vasculitis. So like infections, hep C with cryo, syphilis, and a big one to miss would be endocarditis. They also thought about lymphoma, but this was less likely in this case given the syndrome. And then I think a big, one of the I'd probably like to end with this, and it was very helpful, as Rabi said, that iotitis with subclavian, think Takayasu's, and then if you have iotitis with extracranial involvement, think GCA. So that's like a big difference in imaging that you would get. But thank you so much.
Oh, that was a marvelous overview of a lot of stuff we talked about. Thank you so much, Sukriti. And that NAGM case is outstanding. It's actually last week's NAGM case, so I highly recommend it too. Folks, we're another small announcement. We're doing something we're doing something very special tomorrow, and we have the Washington University program in St. Louis, led by their chief resident Mohit Harsh, who you may know from VMR. They're going to join us on Global Virtual Morning Report with to hang out, to chat about their program, to present a case to us. So it'll be IMG focused, but if you're interested in internal medicine residency, interested in clinical reasoning, but especially if you're an international medical graduate or might be one, join us tomorrow at 9 a.m. to hang out with them in real time. Bye, folks.